So good afternoon, everybody, and welcome to this little interview. I have with me Dr. Chae and Dr. Kim from Seoul, and Dr. Sobotka from basically everywhere in the world, but based in the US. And we will talk about renal denervation, and I will start with some slides and show you what the task of this interview will be. So we will discuss renal denervation, and this is, as most of you know, a new technique to treat resistant hypertension. We will discuss the clinical studies, Simplicity HDN1 and 2, the results and future perspective. We will also discuss about the ongoing trial, which is Simplicity HDN3, which is ongoing in the US, which is a sham trial. And then we will talk about other indications which may evolve with this technique. And these are congestive heart failure, diabetes, and obstructive sleep apnea. Some background information: hypertension is the single largest contributor to death worldwide. Every 20 over 10 millimeters of mercury increase in blood pressure correlates with a doubling of 10-year cardiovascular mortality. There's a dramatic increase of risk of stroke, heart attack, heart failure, and kidney failure. One half of all treated hypertensive patients are controlled to establish blood pressure targets. The other one is not. And this is a high prevalence. It affects 1 out of 3 adults, 1 billion people worldwide. And that means in the year 25, we will have probably more than 1.6 billion people worldwide. 5% up to 30% of all patients with hypertension have a resistant hypertension, which means they, despite treatment, don't reach target blood pressure levels. So what do we know about renal nerves? It has become apparent only actually a few years ago that there are not only afferent nerves going from the brain to the kidney, but there are also afferent nerves, which basically means that there is a direct nerval influence from the kidneys going to the brain. And what these nerves do, they stimulate the central sympathetic tone, and that has a number of effects to different organs. For example, most importantly, vasoconstriction, which means one cause of hypertension. But there are also direct influences on the heart. It's causing hypertrophy, arrhythmias, increased oxygen consumption of the myocardium and heart failure. And there's also some correlation to insulin resistance, and we will talk about this a little bit later. This shows you the time course of the clinical trials dealing with resistant hypertension and renal denervation. We started this with the Simplicity HDN1 in about 2006, 2007 with first in-man in Australia, and then the initial trial conducted in centers in New Zealand, Australia, and Europe. And then this was followed by the randomized trial, which started in 2009. And now, as I said earlier, there's an ongoing trial, randomized with sham control, which is ongoing in the US. This shows you the 3-year follow-up of the first in-man trial, the Simplicity HDN1, and you can see that there is persistent reduction of blood pressure to the degree of minus 33, 34 millimeters of mercury, and this is persistent up to 3 years. And this slide shows you that the number of patients who respond to the therapy is actually increasing over time. So after 1 month, it's only 69%, but then after 6 months, 71%, and it goes up to 100% after 3 years. With the limited number of patients, obviously, at that time. But it seems to be a late response, and the number of responders is increasing over time. This shows you the Simplicity HDN2 trial. You can see that 190 patients had been screened. Some of them had to be excluded for anatomical reasons or other reasons. So 106 patients had been randomized, 52 and 54 in the other group. 3 patients were lost during the course of the trial in both groups. So that means 49 and 51 patients could be analyzed, and most of you have seen these slides. You can see that the blood pressure decreased after 6 months in the treatment group by 32 millimeters of mercury, whereas there was no increase, actually little increase in the other group. And then after 12 months, you can see the persistent reduction in the treatment group, and also, because crossover was allowed, also a significant decrease in those patients who crossed over to renal denervation. So future directions of research there, as I said earlier, there is an influence regarding diabetes, heart failure, sleep apnea, and kidney failure. So these are future fields where this technique will become important. So now let's discuss about different aspects. Let's start with the question long-term efficacy and safety. I would like to ask Dr. Sobotka first. Paul, it could be also these late responders. Could that be just because medical treatment is improving, so the patient is considered to be a failure, so doctor starts to manipulate the drugs, and this could also be the effect why we have late responders?
The late response or the delayed response is an interesting physiologic finding. Clearly, it's possible that changes in medication during that period of time have occurred, but we were very studious in hypertension 1 and 2 to prevent changes of medications during this study period. The late response likely represents a fundamentally different physiology, and there could be, I'll give you 3 possible explanations. The first is that the denervation itself causes a early hypersensitivity to circulating catecholamines, and as that catecholamine hypersensitivity wears away, the delayed benefits are seen. The second possibility is that this is a fundamentally different physiology, that these patients have infinitely non-elastic arterial trees, non-compliant trees, and in order to see a reduction of blood pressure, they have to reestablish elasticity and compliance. And so that this is a remodeling aspect of the peripheral vasculature as well. And the third possibility is it represents a long-term resetting of, we'll call it neuroplasticity, whether it's baroreceptor function or central CNS function, that there's a long-term compensation that takes place. The data nonetheless seems to show that there is a population of patients who appear not to respond early, who nonetheless respond later, and it would appear to be a real physiology, one that we have yet to fully understand.
Dr. Chae, you have started a program here in Korea. What is your experience in clinical practice?
So in Korea, we have around 22% of uncontrolled hypertension among the hypertension population. This data is from the Korean Hypertension Association. So, but the most important thing is how to find real resistant hypertension among the patients with uncontrolled hypertension. This is a big issue in Korea. And we also have some registration data. It's a Korean registry as a part of a global registry of RDN. We enrolled 100 patients and we followed up 6 and 1 year. So now we have 3 months follow-up data. It's not published, but we have 30 millimeters of mercury decrease in systolic blood pressure during the 3 months, and 11 millimeters of mercury diastolic blood pressure drop, and then and also we have some sporadic data from the Asan Medical Center and Samsung Medical Center and Seoul National University. So it's nearly same data compared to the Simplicity 1 and 2.
So are you following in your practice strictly the inclusion-exclusion criteria of the Simplicity trials?
Yes.
Or is it possible for you to make exceptions? For example, patient with blood pressure 150 would have been excluded from the trials.
Yes.
Do you think this is a candidate for the procedure? Do you treat them or do you jet them?
Yes, I am personally, the renal denervation is a very safe and effective treatment modality. So I think it is a good option to treat the patient with around 150 millimeters of mercury systolic blood pressure with more than 3 antihypertensive drugs.
So what is your experience, Dr.
It is
Kim?
very important question. So we basically starting this procedure with some really wanted to real resistant hypertension. So there are many hypertension specialists point out that regarding the hypertension 1, 2, the result is very good. So however, this patient is based on the office BP only. So that's why. So 24 hours ambulatory blood pressure monitoring is very important. That's why we personally in our center, the people they include in the criteria, we almost all done by the 24-hour ambulatory blood pressure monitoring. So we really wanted to that. What is a real resistant hypertension? So that's why. So the initial step, it is on help the belief that. So however nowadays it really is well working in a real practice.
So that means you always do 24-hour blood
Yes.
pressure measurements, and then your cutoff is 160 millimeters of mercury, or is it 140?
Yes, inclusion criteria, we just follow the office BP. However, we some background, some back up the data, we doing the 24-hour is exactly the similar. Some most of the people, some smaller, some compared to the office BP, so smaller than. So however, anyway, almost all patients well met the inclusion criteria.
Paul, what do you think about these inclusion criteria? Is that something which is important to really figure out what is the blood pressure? Is it 160, 150?
I think there's two questions embedded in this. The first is there particular value in isolating the procedure for those with the extremely high blood pressures, 160 and above as opposed to 150? The mathematics of risk reduction for hypertension is linear down to 140. So any patient who has a reduction of blood pressure derives a reduction in their calculated cardiovascular risk. So I don't see an ethical justification to restricting it to the highest blood pressures itself. The use of the ambulatory blood pressure measurement as a criteria raises a different set of questions. What it proposes to do is say that there is a population of patients whose office blood pressures are very high, but whose home blood pressures aren't nearly as high. We call that white coat hypertension. And it may be as high as 20% of the entire community of patients who appear in our offices. Those patients may not require as intense either pharmacologic or therapy or renal denervation. There's an equal population of patients at home whose blood pressures are higher at home than they are in the office. This is called concealed hypertension. And those patients would merit from intensification of their blood pressure management, whether it's pharmacologic or device managed. I personally think that using the ambulatory blood pressure monitor inserts a degree of task interference to getting an effective and safe therapy to our patients. And ambulatory blood pressure monitoring is inconvenient. It causes patients to be up all night with every 15-minute intervals of blood pressure measurements, and it's difficult to get an accurate measurement itself. My personal feeling is that the combination of home blood pressure monitoring and office blood pressure monitoring is more than sufficient to identify patients who are above target. And for target is 140 millimeters, with the exception of patients with diabetes or chronic kidney disease, and their target is 130. Any patient above target would derive clinical benefit, to my knowledge, from renal denervation. And the risk factors are not altered by looking at different communities.
How is the approval situation in Korea? Is the device fully approved? Is there limited release? What is the situation?
Yes, now we are working on it because our government didn't improve right now, but we're working on it with the evidence of the Korean registry, and then we will get the 6 months of Korean data, maybe late in this year or early in next year, will approved by the government as a treatment modality, and then we will have a medical reimbursement system will reimburse the cost. But right now we are now just using the research purposes now.
So that means the Korean government is looking for homemade data in Korea. That's what they want.
Yes,
to have
6 months data. So they are concerned about the long-term safety. So they want Korean data more than 6 months.
Okay, so the Koreans doesn't trust the Simplicity HDN 1 and 2, and the Americans also don't trust these data, and they want to have a sham controlled trial. That is Simplicity HDN 3. So you suggested this randomized sham control trial, right?
No. Horst is teasing me because I am a large naysayer to the additional value of the U.S. trial. The U.S. trial will add 2 bits of information. The first is important. It gives us our first snippet of large data about African American response to the therapy. And that, of course, will be clinically important and important for that subpopulation. The second area is that it adds a sham to the study design. And I'm very ambivalent about the value of the sham. Shams experiments are particularly valuable where there is subjective and not objective data, where there is a large demonstrated placebo effect. And in the case of blood pressure management, we have objective office-measured blood pressures. There's no data that says that these can be subjectively manipulated. And there's no known study that I'm familiar with that says a placebo effect is durable beyond 6 months. So that, to my way of looking at it, the insertion of a sham adds elegance. It's a nice feature, but it is certainly not the least burdensome pathway to allowing an effective and safe therapy onto market. And to that extent, we are costing the American citizens and the taxpayers risk of untreated hypertension and cardiovascular risk embedded in hypertension while we fritter away time doing the studies.
So looking into the future, Paul, looking at the other potential indications of renal denervation, what do you think is the most important one?
Unlike your slide where you talk about heart failure, diabetes, and sleep apnea, my favorite area to pursue is chronic kidney disease and end-stage renal disease. If we have a therapy that can be safely applied that could delay the onset of renal failure even a year, the social benefit and individual patient benefit would be awesome, not to mention the financial benefits. So if I were to lay out a structure for further studies in the United States, I would begin to target chronic kidney disease with the goal of preventing progression of chronic kidney disease, which could come from either the reduction of blood pressure or the reduction of excessive sympathetic drive to the diseased kidney. That would be the clinical population that I think has the greatest potential benefit, and the implications to the country at large would be enormous.
So my opinion is the next target will be the chronic heart failure, because not only heart failure with decreased systolic function, but also heart failure with preserved systolic function. Because preserved systolic function heart failure, so we don't have any treatment tools very effective. So there was a big progress in treating the LV function decreased heart failure. There are many options to treat decreased heart function, but preserved heart function is a totally different story. So the patient with heart failure with preserved systolic function is no more benign. It's a very similar course compared to the decreased systolic function. So I think the most important target is heart failure, especially in the heart failure with the preserved systolic function.
Final words from Dr. Kim?
I love the Sobotka's terminology, new terminology, some sympathetic modulation therapy. I love this terminology. So there are many sympathetic hyperactivity occurred in our body, some result in several adverse effects. So that's why. So this occurrence is concordance with this kind of the sympathetic modulation therapy. This pill is maybe just a starting point. It's maybe the expanded the other some digital territory. It's my personal aspect.
Thank you very much for joining me.
Thank you. You're marvelous.